Hello, I'm Dr. Stephen Self from the Moores Alfred DuPont Hospital for Children in Wilmington, Delaware. I'm very happy to join you for Practical Pediatrics. I am a pediatric emergency physician, and I'm hoping to talk with you about psychiatric emergencies, and I certainly know that you see many of these in your office practice, wherever you practice, and I hope you'll make this practical for everyone. I would disclose that I receive royalties from Elsevier for my textbook, Pediatric Emergency Medicine Secrets, and I do expert legal work, expert witness work for several law firms. And I don't have to tell this audience that mental health disorders are very common in pediatrics. This is a rather old study that shows almost 22% of our country, children in our country, have a mental health or behavioral disorder, and that's definitely changed in the last decade, and certainly in the last year it's changed dramatically. I'm sure all of you are aware that social isolation, canceling school, children are faced with family illnesses, people suffering from COVID, all the economic hardships, children bombarded with social media all day, every day. This has clearly led to an increase in mental health disorders in the last year, and there have been several papers about this. Some are somewhat controversial, or unclear, but I think the bottom line is we're seeing much more mental illness in the last year. In the emergency department, there's an increase in eating disorders, an increase in substance abuse, and depression, high rates of suicidal ideation and attempts. Surprisingly, there have been studies that show there aren't more emergency department visits for mental health disorders. But they usually do come to us in the emergency department. We have been considered the safety net for a fragmented mental health infrastructure. I'm sure you all know we don't have a great infrastructure for mental health, especially for children in the United States, so they all end up, or many of them end up, in the emergency department. And that can be very frustrating. 28% increase in visits between 2011 and 2015 in the emergency department for psychiatric emergencies. It's estimated that 7% of all pediatric emergency department visits relate to mental health. Unfortunately, despite that, only about less than half of the children's hospitals have an inpatient psychiatric unit. We don't have one at my hospital. We're talking about developing a psychiatric unit because it is so difficult to find placement for the patients once they come to us in the emergency department. The sad truth is that when children do come to us, only 16% of them really do see a mental health provider. And that leaves it up to us. We're the ones that end up managing these patients with mental health problems. And Jerry Garcia once said it's incredibly pathetic that it has to be us, but we are the ones, pediatricians and emergency physicians, on the front line that are left taking care of children with mental health disorders. These are the most common disorders, at least according to this one study. Anxiety and panic disorders, I would agree they seem to be the most common, and certainly depression, extremely common now, and we see lots of children in the emergency department with drug abuse problems and conduct disorders as well. The emergency department is not the best place to see a child with a mental health disorder, as you can only imagine. It's a frightening place for anybody. All the lights and all the monitors, all the alarms, very frightening for any child, but certainly a child with a mental health disorder. So the obstacles to care in the office and the setting is and in the emergency department. The physical setting itself is very distressing, as I just said. To many of my colleagues in the emergency department, these are considered undesirable patients. The patients with psychiatric disorders, you know you're going to be in that room for a long time. Time constraints, you have a lot of other patients to take care of. I'm sure you do in office practice as well, and this is not going to be a quick case. I think all of us feel that we don't have the right training to take care of patients with mental health illnesses. We all feel that we lack expertise in this area, and I think all of us know how difficult it is to find a psychiatrist to help us in many situations. I am fortunate we have a great psychiatric department here at DuPont Hospital for Children, but it is still very difficult to find placement for the children, and off hours it's not very likely that we're going to get a psych consult very easily. So what do we do? Well, we can at least screen for mental health problems. I think we do play a major role. Emergency physicians and pediatricians on the front line, we play a major role with these patients, even though we're not trained as psychiatrists. We're the ones that screen for mental health problems. We're the ones who identify risk factors and recognize when there really is an emergency that has to be dealt with. We're the ones who very often offer first-line treatments, and certainly we're the ones that recognize injuries and treat those injuries related to the mental health disorder. And we are the ones that have to decide on whether the patient has a serious problem that needs to be treated by a consultant, and certainly we can help with disposition planning. So let's go through a few cases. The first one is a common scenario that you see in your office as well. A 10-year-old boy jumps from the second floor window onto a trampoline. He falls off and he injures his left arm, and he comes to the emergency department with displaced radius fracture. Seems like a good idea at the start, jumping out of the window onto a trampoline. Seems like a lot of fun. I'm sure you've met patients like this in your practice. This child obviously has ADHD, which is a very common disorder, as you all know. It affects close to 10% of children 4 to 17 years of age, and it is related to prematurity, traumatic brain injury, and child abuse. And about a third of these patients also have other psychiatric disorders and conduct disorders, learning disabilities. Medications are helpful, and I would be willing to bet that most of you in this audience have more experience managing patients with ADHD with the medications than I do. This is something that we don't use in the emergency department. We don't start in the emergency department. It has been recognized that drug holidays are not a good idea. We see many children in the emergency department who are on medications started by their pediatrician or mental health professional, and then in the summertime they go off their medications because they're not in school. So maybe they don't need to concentrate because they're not in school, but then we see them in the emergency department because they're falling out of trees and jumping onto trampolines. So numerous injuries are related to ADHD, as you probably imagine. This is something that I thought that I was biased towards, but I now found numerous papers that show we see many more kids who have injuries related to their ADHD. And can it also result in child abuse? I said child abuse leads to ADHD, but there is evidence that child abuse can result from ADHD. Parents can be very frustrated with a child who's out of control, not behaving well, and that can lead to child abuse. So what is our role? Our role is to find an injury, look for injury with children especially who have ADHD, review their past records, assess the intent of the fall. Are we sure this was accidental, non-intentional, or was this child really trying to hurt themselves? And consider restarting their medications or getting them to a pediatrician to start the medications. Again, it's not something that I do in the emergency department setting, and I'm sure many of you have a lot more experience medicating patients with ADHD than I do. So let's go through another case. This is a 6-year-old girl. She ran away from home 4 times in the last 2 weeks. The mother brings her to us because yesterday she ran across the highway, and today she jumped out of a window from a height of about 4 feet. So she didn't get hurt, but mother recognizes that this child has a serious problem. She's going to get hurt. A serious injury is going to result. She's doing poorly in school in the 1st grade. Her teacher is giving her bad grades. She had a recent emergency department visit for a dog bite, which is not a surprise. Many children with ADHD are playing with dogs and don't realize that they're agitating the dog and the dog snaps at them. So we see many children with dog bites who have ADHD. This child has normal vital signs. Her exam is normal. She's very happy and affectionate, but she's difficult to examine because she's running around the emergency department, turning on the sink, turning on the lights, pushing the nurse's alarm. It didn't take more than a minute to make the diagnosis of ADHD in this patient, even though she's very young. She has no obvious injuries, but the mother is clearly frustrated. She's at her wit's end, and as I said, this is a mother, she was a wonderful mother, but I was worried that she was going to hurt her child out of frustration if we didn't do something for this family very soon. So I think, again, our first goal is to recognize that we have a problem. This is not normal 6-year-old behavior. I've seen it in a 5-year-old just recently, a very similar case. And someone had told the mother, well, that's the way 5-year-olds act. But I think all of us would recognize this is not the way a normal 5 or 6-year-old should act. So severe ADHD, this is not a parenting problem, but it is a very serious problem for the parent. Our goal is to get the child completely undressed and look for injury and look for inflicted injury. Again, It could be a frustrated parent who just takes it out on the child who's misbehaving and difficult to control. This family obviously needs urgent help, and we were able to contact our social workers to arrange for crisis counseling and a behavioral evaluation. This is not one that can wait for 3 months to be seen in a developmental behavioral clinic. Here's another one, a 14-year-old girl out of control. She argued with her teacher, and then in the process of this, she flailed back and hit her head on the ground. She hit her head repeatedly on the ground. She didn't lose consciousness, but she comes to us now with a headache and photophobia. No surprise about that. Her past medical history, she does have some psychiatric problems of obsessive-compulsive disorder and anxiety disorder. She hasn't had any recent counseling. Years ago, she was seen by a counselor. She's supposed to be on risperidone, but she's not compliant with this medication. Social history, she lives with a friend and the friend's father. So there's some pathology right there. Where are her parents? Her father is peripherally involved. Her mother has mental illness and drug abuse problems, and she's not involved with the child's care, but the patient's not even living with her parents. She denies sexual activity and vaping. She denies use of drugs. A physical exam, her vital signs are normal. She does have a quiet, flat affect. She has some mild head injury there, as you might expect, but multiple linear scars on her forearm from cutting behavior and an infected tattoo, by the way. We decided to do some screening, some adolescent screening, even though she denied sexual activity. I think this is somewhat controversial. Not everybody believes this should be done with every adolescent that comes through the door, but while we had her in the emergency department, now her quiet mood changed and she became very agitated and uncooperative. So how do we manage this? I think initially we wanted, if it's mild agitation, we're going to just try to do some calming interventions, talking to the patient. If there's much more moderate, much more aggression on the patient, then we might resort to some medications, diphenhydramine, benzodiazepines, and if it's very severe, then we're going to have to take further action with neuroleptics. So first we're going to try to remain calm, keep the patient calm, speak softly, try not to be judgmental. I think it's very important to space yourself appropriately from the patient. The patient doesn't want you hovering over them, but they're also going to notice if you're very distant from them as well. I would also say to space yourself safely so that you can get out of that room if necessary. You don't want to have the patient blocking the door. You want to be closest to the door so in case you have to escape the room. Avoid intense direct eye contact. Set some limits, so we can't let the patient throw chairs, we can't let the patient do things to hurt themselves or cause severe damage to the room, but if they're just tearing off the paper off the exam table, we should try to avoid confrontation and allow that behavior to continue. So again, this is what's recommended at my hospital. It's not universally done, and I think you could use diphenhydramine, you can use lorazepam orally if the patient is willing to take it for mild agitation. Moderate agitation, we're going to usually refer to haloperidol, but honestly, my recommendation is just to get familiar with one agent. I usually use haloperidol. That's what I've been using for years, and so if there's moderate to severe agitation, that would be my go-to medication. And certainly in severe agitation, there's no way you're going to be able to give oral medications. The calming behavior is not working here anymore. We're going to need to give an injection, an intramuscular injection, and usually haloperidol would be my drug of choice, but everyone could be familiar with different agents. I'm sure most of you don't have to physically restrain patients. In the emergency department, we occasionally have to apply restraints. And I think when we make that decision, we have to make it for real and use leather restraints. You can't do it halfway at this point. So leather restraints are important. We need to get multiple caretakers, one on each extremity and one on the head, to manage the head and neck, and try to be sympathetic and try to be calming as we're doing this, try to explain to the patient what we're doing, whether they're hearing you or listening to you. I'm not always sure that's true, but check on the patient frequently. It's not a violation to put the patient in restraints, but it is wrong to walk away from the patient and not check on them frequently. And the one caveat that we should all be aware of is never restrain the patient in the prone position. I'm sure you've seen numerous tragic results of this with police restraints across the country. It's never a good idea to restrain a patient in the prone position because it does limit their ability to breathe, and that could lead to respiratory arrest and cardiac arrest. Here's another case. A 6-year-old boy has a seizure at home. He has a known seizure disorder, and he's supposed to be on medications, and he lies and tells his mother he took his medications, but she found some under his pillow, and when confronted, the child told us that he hates to see his mother worried. He wants to go to heaven, so she will stop worrying about him. Unusual to have a 6-year-old with such serious thoughts, but as we find out, the parents are separated. They're still fighting bitterly. In fact, in the emergency department, I could see the father kicking the mother under the table. The child lives with his mother, but his father is involved. Both parents are shouting. It's not a good situation. And this is a 6-year-old, obviously, who has depression. And again, it's unusual to see this, but it does happen. I think many of us think that 6-year-olds are too young to be depressed, but that is not the case. It is common even in prepubertal children, even in preschool children. In fact, it's estimated that 2 to 4% of children at this young age group have depression. And certainly going to be increased. The incidence is increased if the parents are depressed. It's usually if the mother is depressed, the child spends a lot of time with that mother. If there's a serious chronic illness in the family and the mother is depressed about that, it's going to lead to depression in this patient as well. Divorced parents could be a risk factor, and certainly child abuse is going to lead to depression, obviously. And it doesn't have to be physical abuse, but it could just be verbal abuse. A child who's verbally abused constantly is obviously going to be very depressed. So they present to us, I think, the obvious findings of overt sadness, low self-esteem, hopelessness, helplessness, suicidal ideation in some situations. We'll talk about that next. But I can tell you it's not always an obvious diagnosis. They don't always come to you with the diagnosis written on their chest. So there are subtle presentations, and I'm sure many of you are aware of that, but frequent visits to your office or to the school nurse office. This could be a sign that the child is depressed. Frequent somatic complaints. It's estimated that about 10% of the children who come to us with chest pain have a psychiatric problem, or at least depression as the cause of their chest pain, or stress-related chest pain. So school avoidance and failure. Many of these children are injured because they don't care about themselves. They're so depressed that they're just not being careful when they cross the street or in their daily activities. So reckless behavior could lead to injury. It certainly can lead to drug abuse, sexual encounters, and eating disorders. Here's another case, a 16-year-old girl, vomiting, abdominal pain. She presents to us, brought in by the paramedics. She lives with her mother and her grandmother. She's had trouble today. She argued with her girlfriends today, and this is on top of breaking up with her boyfriend in the last week. So her only support system, these girlfriends, she lost them today in an argument. She took some acetaminophen. She also took her grandmother's digoxin. She said goodnight to the family and then went to bed. She didn't tell anyone about the pills. Fortunately for her, she woke up vomiting with severe abdominal pain, and her grandmother called 911. She was brought to the emergency department, and when we called the family, the mother refused to come. We called to say that your daughter's here, and we're worried about her, and the mother said, well, I have to work tomorrow. She did this to herself. I'm not coming to the hospital. So there's a red flag right there. This is a patient who had a real intent to kill herself. She did not tell anyone about the pills. She was fortunate that she woke up in the middle of the night, but her intent was to not be found. And unfortunately, suicide is a major problem among teenagers, as you probably know. It's estimated in 2013 that more than 1,700 teens killed themselves, and this number is probably underestimated. Many children who die from an accident and non-intentional injury may very well have a planned suicide that was just not discovered. And for every suicide, there's estimated to be 50 to 100 times as many attempts. In fact, it is considered the second leading cause of death in this age group of 10 to 19-year-old patients. So a major problem in pediatrics. Males are much more likely to be successful. Females much more likely to attempt suicide, but males are more likely to be successful. And the reason for that is that males are going to use more violent means to attempt suicide. More use of guns, more hanging, whereas females are more likely to attempt suicide by drug ingestion. This is changing. This is recently changing as females now have more access to guns and are attempting more violent approaches to suicide. So we are seeing this gap narrowed a bit in recent years. In the last year, one survey showed that 16% of teenagers seriously considered suicide, 13% actually planned an attempt, and 8% of the teenagers in the survey attempted suicide. Staggering results. So suicide is much more worrisome in adolescents who have attempted suicide in the past, and that makes it very important for us to recognize those patients. It has been shown that 50% of patients who attempted suicide sought medical care the month before, and then 25% of the time they sought medical care the week before. So that implies that maybe we do have a chance to intervene if we screen patients for depression and suicide. Every patient, every adolescent that we see, we have a chance to pick up some of these cases before their suicide attempt. Factors that increase risk: obviously a teen with a previous attempt is at a higher risk for suicide, for a successful suicide. If there's a family history of psychiatric disorder or suicide, those children are at higher risk. History of depression, runaway, loss of self-esteem, like the patient that I showed you who lost her support system in an argument and lost self-esteem, clearly at high risk for suicide. Major loss of death of a loved one. We do see this sometimes. Patients in mourning, patients who are spending time at the cemetery after they've lost a loved one, an unusual time at the cemetery. Parental divorce in young children, children in foster care, abused children clearly are at higher risk for suicide, and I'm sure everyone is aware that children who are sexual minorities, transgender youth in particular, have a very high risk of suicide, as well as those who are substance abusers and those who are at risk for bullying. Bullying has lately become recognized as a major cause of suicidal ideation, and I'm sure all of you know in pediatrics how common bullying is. It's estimated that 24% of girls and 50% of boys have been bullied at school. Many of them are bullied online, and this can result in school avoidance, poor school performance, and certainly increases the risk for suicide. And I hope you also recognize that the child who's being bullied is not the only one in trouble. The one who's doing the bullying is also at risk, likely to be depressed as well, and may have some suicidal risk in that person as well. So this is how it usually pans out. The patient has a chronic stressor. They live in a foster home, or they've been sexually abused, maybe a drug abuser. So this is now a vulnerable adolescent who comes across an acute stress that we mentioned. An arrest, found cheating at school, found to be pregnant, a rejection or an argument with friends, and now that child, that vulnerable adolescent, goes on to attempt suicide. So what can we do? Our role as pediatricians and emergency doctors is to identify and manage life-threatening conditions. So our first goal when we have a patient like this child who ingested all those pills is to manage the ABCs, make sure this patient is breathing adequately, make sure her vital signs are stable, consider the life-threatening complications of that drug ingestion. We're going to look for associated trauma. Maybe she had an injury after her attempt her suicide attempt. We should consider organic etiologies for a patient who is not acting normally. Could there be depression related to other medical conditions? It's extremely rare, but it does happen. There are patients with thyroid disease. We have some patients with autoimmune infections of the brain who have very strange behavior. Lupus cerebritis, medication side effects, Wilson's disease, all of these have been reported to cause psychiatric problems in children, although they are extremely rare causes, but they have to be considered. So what do? We want to interview this patient in a quiet, safe, comfortable room. As we mentioned before, avoid excessive closeness, but don't be too far away from the patient that they notice that you're avoiding them. I think it's probably a good idea to talk to the child and parents together, but clearly we have to separate the two and get their individual stories about what's going on at home. This is a situation we usually count on the families to give us a good history, but this is a situation where the family may not be helpful because, as we said, mental illness often runs in families, and that mother may very well have mental illness herself and may not be a good historian. So a gentle, sympathetic approach. We want to ask, how's the child sleeping? How's he eating? What's her energy level like? Are there somatic complaints, headache, chest pain, abdominal pain? How's school going? Have there been multiple visits to the school nurse? Is the child withdrawing from friends and family? Is the child acting out? Have there been any suicidal attempts? And certainly we want to ask about family history of psychiatric illness. What are the risk factors at home? What's going on at home? Are there stressors at home? And then we have to look at the attempt itself. Was this a serious attempt? Did this child intend to kill herself? Did she have a rescue plan? Did she disclose the ingestion in time to be saved, or did she really not want to be saved? Was it a planned event that the patient's been thinking about for a long period of time? That's obviously more worrisome than a child who just spontaneously took some medications. Was the attempt lethal? Was a gun used? Was it an attempted suicide by hanging? Those are clearly much more worrisome. And does the child have access to weapons and access to drugs in the house? Is the child still thinking about suicidal ideation? So there's all kinds of screening tools out there, and I'm sure many of you are well aware of these and very experienced with this. My residents do a heads exam on just about every patient, every adolescent that comes into the emergency department. They're quite good at asking all of these questions and finding this important information, but it doesn't have to even be this extensive. Joel Fine and Steve Porter many years ago published a quick screening exam in the emergency department. How's school going? How are you feeling? Who do you talk to when you're sad? What are your plans for the future? And others have developed even simpler screening tools, a two-question screening for depression. Are you feeling down and depressed? Do you have a little interest or pleasure in doing things? This is thought to be very sensitive and specific. And then again, there are other screens for suicide. Have you ever felt life is not worth living? Have you ever thought you wanted to kill yourself? Two pediatric clinics studied this, and they found very successful at detecting suicidal ideation in teenagers in this study. So again, we have to do a physical exam. This is an important role for pediatricians and emergency physicians. What's their overall health? Is there any evidence for trauma? Is there cutting behavior? Fortunately, it seems that cutting behavior is not a great risk factor for suicide. In fact, it's more likely to be a release for the patient, and it may correlate with psychiatric illness and depression, but not necessarily a suicide attempt. And then we're going to do a mental status exam. And again, here I think most of us feel that we don't have expertise in doing this, so I'll try to simplify that. I would say as a non-psychiatrist, we just want to keep it simple. We just want to do the ABCs. What's their appearance like? What's their affect like? What's their behavior like? And what's their cognitive thinking like? And if you can just do this exam, I assure you, you will pick up many important conditions, and you will impress your psychiatrists or your mental health workers that you refer to. So what's their appearance and their affect like? Does the patient look disheveled or well-groomed? Is he or she taking care of herself? What are the facial expressions? What's the affect like? Is the patient flat affect, depressed? Is the patient very labile? What's their behavior like? Are they violent? Are they rocking, pacing, cursing? Or is the patient cooperative for your examination? And then what's their cognitive behavior like? Are they thinking rationally? Are they delusional? Do they have hallucinations? What's their judgment like? Does the patient seem oriented or not? Again, just doing the simple ABC exam is going to be very helpful in picking up mental illness and getting a proper referral. So for depression, we obviously want to consider a psychiatric referral. I think my advice would be, and the advice of others, is to communicate with a psychiatrist in advance. Don't just tell the family to make an appointment. Give them a specific name. If at all possible, make contact with the psychiatrist. And now that the family already has somewhat of a bond and feels closer to the psychiatrist, and they're much more likely to call in that situation. If for a suicide attempt, clearly everyone has to be seen by a psychiatrist. We would never let a patient leave the emergency department without psychiatric intervention. We might consider outpatient management, and with the help of the psychiatrist, if the suicidal ideation has subsided, if there's a strong family network. So the patient that I presented to you where the mother wouldn't even come to the emergency department, we obviously can't plan for outpatient management of that child. It would not be safe when the mother is so disinterested that she's not coming to the hospital. And if we are going to do outpatient management, there has to be a follow-up appointment within 48 hours. Keep in mind that most adolescents who are referred for outpatient management after a suicide attempt fail to keep their appointments. And this was by the AAP Committee on Adolescent Medicine, where they found this sad result that just saying to the family, just thinking that you're going to get outpatient follow-up, many of them don't keep their appointments. So for a suicide attempt, who should be admitted? Well, certainly if the patient has a real wish to die. And again, the adolescents that I presented to you who took the medications without telling anyone had a real wish to die. If there's a lethal means, if they're using a gun or a rope, and they were fortunate enough to be unsuccessful, that patient clearly needs to be admitted to the hospital. If the parents are unsupportive or saying, oh, this is nothing, I'll take care of her, this is not a serious problem, those children should be admitted to the hospital. And if this is not the first attempt, the child who's made multiple attempts to kill themselves, sooner or later they're going to be successful. It's advisable to admit those children to the hospital for inpatient management. So our goal really is to prevent the next attempt, obviously, and it's not as easy as it sounds. So we have to clear the house of guns. Not so easy. Many families are still unwilling to give up the gun in the house despite that the child has used this or threatened to use a gun on themselves. And we also need to get rid of the medications in the drug cabinet. This would be very important. And also, this is not so easy to do. Many families don't clear out all the medications in the house. All right, well, this is a very depressing topic to talk about, suicide and depression. So I want to change gears here a little bit for a few minutes to talk about cases that I think are much more fascinating and certainly easier to digest. Let's talk about somatic symptom and related disorders. We used to call these conversion disorders, but this is the newer term. So I'll give you a case of a 10-year-old girl who's had multiple coughing spasms for the last 11 days. Her cough is worse in the evening. These spasms can last for a long period of time. She's had no fever, no apnea, no cyanosis. She does have a sore throat. You would too if you were coughing for 11 days. She has abdominal pain. She's had some post-tussive emesis. And she's been to the primary doctor multiple times. She's been to 2 emergency departments. She's been out of school for a whole week. The school won't keep her in with that cough. They threw her out of school. She's had chest x-ray that's normal. She's been on multiple medications. None of these seem to be working. I think at this point it's pretty easy to look back and say this is probably not an organic diagnosis. She has a history of being hospitalized for croup. She has a cousin with asthma. Her physical exam, vital signs are normal. She doesn't seem to be in distress, but she has a very loud cough. In fact, I remember this patient, the nurse came to me and said, I can hear this child all the way down the hall. You're going to have your hands full with this child who's coughing so loud that you can hear it down the hall. Her chest was clear. Her exam was otherwise unremarkable. So this is a patient with a psychogenic cough. Our clinical picture suggests a physical disorder, but it's really an expression of a psychological conflict or need. It's not intentionally produced, so it's not thought to be that she's malingering, but it can't be explained by a physical problem or pathophysiologic mechanism. So these are very common. I'm sure you've met many children with somatic symptom disorders or conversion disorders. The incidence is not really known, but it does seem to be much more common in the girls. And in young children, boys and girls are equally affected, but in adolescents, it's much more likely to be an adolescent teenage girl. It's unrelated to socioeconomic status, so it's probably related to stress, and it doesn't matter the socioeconomic status of the family. It is more likely if there's parental discord or divorce, child sexual abuse, so again, stress involved, and in some cases there's secondary gain for the parent or the child. In fact, one of the children that I saw with a psychogenic cough, a conversion disorder, the father now, who was out of work, had to stay home to take care of his child who was thrown out of school. So there was some secondary gain. This father now has a role to play. He was feeling very depressed himself because he was out of work. And both the child and father are very happy that now they're getting to spend more time together. That never used to happen in the past. So this psychogenic cough, the patient I presented to you, is pretty classic. It usually begins with a simple cold. The cough is loud and disruptive. The child is thrown out of school, yet she's able to sleep pretty well. She's had multiple doctor's appointments, multiple treatments, but nothing seems to work. So again, our approach here is to consider an organic etiology. Is there a life-threatening problem? Could this be reactive airway disease or a foreign body? But don't spend too much time thinking about this. As I said, this child's had multiple visits, has been on multiple medications, has had a chest x-ray. This is not an organic problem, and we don't want to focus too much time trying to find one. We want to interview the child and family separately again, if possible. When we did interview this child, we found that she could speak to us in full sentences, but she would often defer to her family to answer the questions for her. Many of these children have labellar indifference. Despite being out of school for a week, the child seems pretty happy with the whole situation. Very important to ask about stress at home. Always a good idea to ask the parents, what do you think is going on? In some cases, the mother has already said to us, you know what, doctor, I'm starting to wonder if this is related to stress. We've tried a lot of medications. She seems to be under a lot of stress. Do you think the cough could be related to that? If you have a parent who gives you that answer, you're golden. Otherwise, it's sometimes difficult to convince a family that that's the etiology for the child's symptoms. So the physical exam is usually normal. The cough can often stop on command. Again, it's not the same as malingering, but in some situations, I would tell the child, you have to stop coughing for a minute so I can listen to your chest. Sure enough, there's no cough for a minute or two, and then it starts up again. So our management will be to assure the parents that we're going to take this very seriously. We're not going to just blow this off. We're going to order any necessary tests, but we're not going to order tests that are unnecessary. You have to be confident in the diagnosis. If the family suggests that or suspects that you're not really sure what's going on, they're going to challenge you to get more and more laboratory studies. I will often talk to the family and use the analogy of like a headache. We know that children get headache when they're under stress. They can get a cough like this and other symptoms like this when they're under stress as well. It's not that she's making this up. She's not malingering, but we don't want to give her unnecessary medications or unnecessary tests. This is a situation where the patient clearly needs some counseling and some therapy. So my last case is a 15-year-old girl who presents with menstrual cramps. She went to the school nurse because of her cramps, and at the school nurse it was noted that her eyes rolled up in her head and she fell to the floor. She was actually lowered to the floor. She didn't get hurt. She was transported by EMS to the hospital, and they reported en route her eyes were fluttering. She was shaking her arms and legs. She was unresponsive. And on past medical history, we found she's been admitted to a hospital twice before for seizures. She's been on anticonvulsants briefly, but she stopped these on her own because of side effects. Here's her vital signs. They look quite normal. She's not responding to voice or pain. She is shaking her arms and legs in a very irregular way. She has some cardiac irregularities, just to throw in a wrench there and maybe throw us off course. This is really what happened. But her exam is otherwise unremarkable. These cardiac irregularities are unrelated to her current problem. She was given, this is not at my hospital, but this patient was given multiple medications at an outside hospital, showing you how serious this problem can be. Neurology was consulted, and even I think the neurologists were fooled initially. But her blood gas was completely normal. So I think there's a lot of clues here that this is a patient who has a somatic conversion disorder, not a true seizure, because you would expect abnormalities of the blood gas and abnormalities of her vital signs if it was a true seizure. So this is a psychogenic non-epileptic seizure. We used to call them pseudo-seizures. And I think you'll recognize this. There's bilateral motor activity with bizarre, uncoordinated movements. It's not the same rhythmic movements that you would see in a true seizure. Often there's cursing and groaning. There's usually no bladder incontinence, which may happen in a generalized seizure, obviously, but in this situation there's rarely urinary incontinence. And there's no autonomic changes, so the vital signs are normal. The patient may wake up after a long period of shaking. The patient wakes up and is perfectly back to himself. In a true seizure, the patient would be unresponsive for a long period of time. So this is a chart just to compare the two. There are no rhythmic movements with these pseudo-seizures. They can have purposeful movements. They can reach up and grab your stethoscope in the middle of this, quote, seizure. And there's usually no incontinence, and there may be some moaning sound. So they may actually be conversing to you during this, and sometimes you can coax the episode. Again, this is not malingering, not the same as malingering, but in some situations I've come across a patient where we thought they were having these non-epileptic seizures, and we said, boy, if only we could have seen one of these episodes. And a minute later, the child starts to have bizarre behavior. So they can be coaxed in some situations. So our interview is going to be difficult. This child can't be interviewed. They're unresponsive. The parent may report that the child has a seizure disorder, and in some cases the child does have true seizures on top of these psychogenic non-epileptic seizures. They have often been on anticonvulsants. They may have other psychiatric problems. If you can get a hold of old records and see that someone's already made this diagnosis, that would be very helpful. But our role, again, as emergency physicians and pediatricians to make sure the child doesn't have a life-threatening condition, look for those purposeful movements. And some people say if the patient's unresponsive to irritate them or put a cotton swab under their nose to try to get them to move. I think this is a little bit maybe not very kind, but it can be helpful in the diagnosis. So if you really want to make the diagnosis, the gold standard is a video EEG while the child is having this activity to document that this is not a true seizure. Others have shown that if you ordered prolactin levels, they would be elevated in a true seizure, not elevated in the psychogenic non-epileptiform seizures. But most of us don't go that far to get blood studies. Probably we're going to get neurology involved to prove that this is not a true seizure, but I think we can make the diagnosis clinically, or at least have a very strong suspicion clinically. Admit these patients to the hospital. I think rather than outpatient management, we will do that in some situations, but as you can see, this can be a serious problem. This child could go to another emergency department and get intravenous medications that could be very dangerous to the patient. So consider immediate psychiatric help for this patient, and it may require admission to the hospital. Avoid the anticonvulsants if you're convinced this is not a true seizure. So to summarize, children frequently present to us with psychiatric emergencies. They're going to come to your office. They're going to come to the emergency department. We see many, many patients with ADHD, with out-of-control behavior, depression or suicide, and certainly we see many patients with somatic symptom disorders, and all of us play an important role in the initial management of these patients and certainly making the diagnosis for these patients. So as a result of this talk, I hope that you will screen adolescents for depression. I hope that you will consider somatic symptom disorder when the symptoms don't seem to add up, don't seem to make sense. Thank you very much.